A very good afternoon to all our viewers out there. We are back with our new program on cardiology and diabetes management. Today, we will be talking about latest advancements in cardiology management. Our first speaker for today is Dr. Tejas Patel. Without further ado, I would request the doctor to please start with presentation.
So I'm going to talk about the intravascular lithotripsy, which is one of the latest modality came into the world of coronary angioplasty. In fact, it has been used in the peripheral angioplasty, also in the selected cases. So what is it? Let's go with the case first. 54 years old gentleman, hypertensive, diabetic at PTCA to mid RCA 5 years back, presented to us with the acute coronary syndrome, positive with acute LVF. Ejection fraction was 25 to 30% with moderate mitral regurgitation, and there was a new regional wall motion abnormality of the infralateral wall in the echocardiography. So initial medical stabilization followed by angiography, what we planned, and you can see this is the angiography. The left system was mild to moderate disease. I am not going to show it here, but it was severely calcified. You can see it in this image also. This is a calcification on the left system, and this is the right coronary artery, which was proximally showing 70-80% of the eccentric lesion. You can see it in this image. And it was a very right coronary artery, and the branches are going almost up to the apex. We started with the OCT. You all know that optical coherence tomography, it is one of the latest modality to know the plaque morphology better, and accordingly we can treat the patients, and before stenting we can modulate the plaque before putting the stent. So this is the OCT run, and you can see there is a huge chunk of calcium, almost the ring calcification in a couple of places, along with the fibrofatty plaque, and some sort of there is a small thrombus burden also at some point of time at some images at some level of the right coronary artery. It's a huge artery, some fibrocalcific plaque also, but the main thing is there is a nodular calcium at a couple of places. You can see it here. This is the calcium which we can see it in the OCT. It is an enlarged image. You can see it here. This is a huge calcium, and there were ring calcification almost at a couple of places in the patient. We did OCT because there was a calcific image in the coronary artery itself, especially on the left system. And we were also suspecting the calcium, similar calcification in the right coronary artery as well. So we need to treat this calcium before putting the stent to optimize the outcome and the long-term, to prevent the long-term adverse events. So you can see it here with the pre-dilatation of the NC. You can see this is a dog bogging of the balloon. It was a 2 millimeter of the balloon. And you can see this is a calcium which is there in the plaque, RCA plaque. And there is a dilatation in the proximal and the distal segment, but there was no dilatation properly. There is no yielding, in fact, in the middle part. That is called as dog bogging, and which was there with the even 2 mm NC balloon. So we use shockwave IVL therapy. This is a simple system. Basically, it is made up of one console, and this is a catheter. The catheter is connected outside the body in the cath lab itself, and to this console, and this part of the catheter runs over the wire. This is a OTW catheter, almost almost a proximal portion. You can see it here, which is delivering the shock, and this rest of the portion outside the body can connect it to the catheter and to the console. This balloon is a special balloon. There are 2 emitters in that balloon, which releases the pulse shock wave to the plaque. So we can place this balloon in the calcific coronary plaque, calcific coronary block, and we can just switch on the balloon, switch on the console here, and these emitters can release the radio frequency, release the energy in the local portion of the plaque, and that will break the calcium. So you can see it here. This is the IVL shock. This is the IVL balloon, and you can see that there will be some bubbles here. When we deliver the shock, there will be some bubble appearance. You can see it here. Are there. That means that it is delivering the energy in the local place, and you can see the expansion of the balloon at the same time. So this is the IVL shocks which are getting delivered into the local place of the block, and which is cracking the calcium, and the artery is getting expanded at that place. and the bubbles are showing that we are delivering the shock. The entire balloon, it is outside. It is a simple balloon system that is connected outside to the console, and through which we can deliver the shocks to the coronary artery. So after the putting the stent, you can see it here. This is a distal mid RCA stent, and this is the proximal, the new stent which we put there, and this is the final result after the angioplasty. So it was a satisfactory result without any complications and good flow distally. So challenges of treating calcific coronary lesion. We all know that based on the various data and the various study, calcific coronary lesions are associated with increased adverse cardiovascular outcomes as far as the long-term CV outcome is concerned. Calcium scoring system. This is the OCD-based calcium scoring system, and based on that, the angle of the calcium, let's say it is a ring calcification, or how circumferential the calcium is, the thickness of the calcium, and the length of the calcium, through which we can define the severity of the calcium, and all these things we can measure inside the coronary plaque through the OCT. So OCT demonstration of this calcific plaque, and you can see that after delivering the IVL, you can see there is a cracking of the calcium, and that will give the immediate luminal gain, and later on the very good stent apposition and the long-term good outcome. So this is the IVL impact on the calcium, coronary artery calcium, and based on the OCT finding, we can use the IVL, or we have to modify the calcific plaque accordingly. So based on the CT angiographic intravascular imaging data, if the patient having heavy calcium, that category is based on the calcific angle. Let's say if it is half circumferential calcium, the thickness of the calcium is more than 0.5 millimeter, and length is more than 5 millimeter. We need to modify that calcium before putting the stent to get the optimized result, and that we can do it with the simple NC balloon first. If we feel it is a really ring calcification and it's a very severe calcification, we can either use a rota ablation or the IVL. You all know that rota ablation we have been using since many years, and there are various drawbacks, advantages as well as disadvantages. But I would say rota ablation, IVL is much more safer than the rota ablation, except that IVL balloon cannot go inside the calcific block. We cannot place the IVL balloon in the calcific plaque. We need to use the rota. Otherwise, IVL is very, very safe, and it is very, very effective to break the calcium in the coronary blocks. Thank you very much.
Thank you so much for your talk, sir. So our next topic is the new technology in cath lab IVL, which will be taken by Dr. Keyur Parikh.
Hello, everybody. Today, I'm going to talk on a new technology in the cath lab called IVL, which is Intravascular Lithotripsy. This is a case which I did along with Dr. Urmil Shah and Vipul Kapoor a few weeks ago. This is a technology which I'll talk a little more later on, was released in India about a year ago, last January, but because of COVID, did not evolve as much. We did the first 3 or 4 transradial lithotripsy cases last January. This case was done a few weeks ago when a 61-year-old gentleman came to me, non-diabetic, hypertensive with increasing angina. ECG showed right bundle branch block. 2D echo showed mild inferior hypokinesia with normal valves. As you see in the angiography view, the right coronary artery is totally occluded, and the left coronary artery supplies collateral to the right coronary artery. We started using various chronic total occlusion special wires, and eventually we were able to cross the lesion. Having crossed the lesion, we tried opening with different balloons. What we found was there was a dumbbell shape, non-expansion, non-dilatation at the center. Despite trying various balloons, we found out the lesion could not be opened up and there's a tight residual lesion. Then we went ahead and used rotablator. Rotablator is a diamond coated burr, which rotates at a very high frequency, rotational per minute up to 150,000, which I've been using for over 25 to 30 years. And despite that, it didn't open well. As you see here, this is a diamond-coated bar which tries to ablate the atheromatous and calcific plaque and creates a smoother lumen. And having done that, it gets easier for stent to go in and be implanted. In this case, we were unable to expand the lesion again, and the balloon, as you see here, did not open at the center. Because of the excess contrast which was given on that day, we postponed the procedure, brought him back after a few days, and decided to use IVL technology. The lesion was still there, and we used a guide catheter and a special catheter and used this technology called IVL shockwave catheter. IVL system consists of a portable rechargeable generator, a connecting cable push button to manually control delivery of electrical pulses. This is the generator, this is connector cable, and this is the balloon. And it's a lithotripsy catheter like renal lithotripsy. There are two emitters which emit the shock waves. The system is very portable.
The shockwave intravascular lithosystem creates pulsatile sonic pressure waves to modify calcium in a safe manner. It consists of a compact rechargeable generator, a simple connector cable, and an intuitive catheter, which houses an array of lithotripsy emitters enclosed in an integrated balloon. Through the localized delivery of lithotripsy, the IVL system minimizes trauma, optimizes outcomes, and simplifies procedures. In a standard technique, the IVL catheter is advanced and placed at the lesion using marker bands under angiography, with the integrated balloon expanded to subnominal pressure of 4 atmospheres by a mixed saline and contrast solution. The fluid within the fully opposed balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. With emitters along the length of the balloon, a localized field effect is created. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the sonic pressure waves and then collapses within a few microseconds. When the waves impact the calcium at nearly 50 atmospheres, they create a series of microfractures. After the calcium has been fractured and trauma to the surrounding soft tissue has been minimized, the vessel becomes more compliant. Once lithotripsy has been completed, the operator can proceed with the preferred treatment strategy to optimize outcomes. By making the treatment of calcified lesions more predictable, IVL is simplifying complex procedures.
Now I'll show you how it works with this another wonderful video.
Depending how calcium presents, the number of IVL pulses to achieve an optimal result are different. When the IVL balloon expands in eccentric calcium, the emitter moves away from the calcium, since the soft tissue is not constrained. The farther the emitter is from the calcium, the less energy is able to reach it, so more pulses are needed. While each pulse's energy is identical, shock waves crack concentric lesions quicker due to the rigid ring of calcium that traps the energy, leaving no other paths to dissipate other than cracking. Waves also reflect off calcium and impact the calcium in the opposite wall. In eccentric lesions, most of the waves pass through the soft intima, and there is negligible benefit of reflecting waves. Regardless of how much energy is required, the efficacy of the shock waves is evident under angiography.
So having used shockwave, then we did a OCT where we saw the entire fractured calcium, as you see here, and the artery had opened up even much more. Subsequently, we were able to deliver the stent and open the artery. And as you see, finally, excellent result was achieved. This is the first case of rotablator assisted intravascular lithotripsy in Gujarat and possibly in India. This is the nicely placed stent in this artery. We had another patient also, severe left main into LAD calcific lesion, which another hospital was unable to open the lesion. We went ahead with the shockwave IVL catheter, as you see here, eventually using using multiple shockwave impulses, we were able to open the artery. Again, you see the fractures in the calcified area. This is another residual calcium. And this is again, as you see, the pre-COVID era, last January. And these are the emitters, lithotripsy emitters, which emit using a rapidly expanding bubble, emit the waves, and high-speed sonic pressure wave created inside the artery, inside the balloon and into the artery, opens the lesion. And again, this is intimal medial and how the calcium is cracked. We're able to deliver the stent and open the artery. There's a side branch dissection, which also was opened up. And a very complex case was done about a year and a half ago. So I'll stop here and thank you very much for attending this conference. It's been a fantastic last year. When I say fantastic, because we had the world's worst pandemic, we came with the vaccination and we have bounced back. Thank you very much, everybody.
Thank you so much for the insightful presentation, sir. Moving on to our third topic, which will talk about cardiac devices. What is there new on the horizon? This topic will be conducted by Dr. Ajay Naik.
In the next 10 minutes, I'll briefly talk about cardiac devices, what we are doing now, what is new on the horizon. I'll be talking briefly about pacemakers, conventional what we are doing now, and leadless pacemakers, conduction system pacing, which is new last couple of years, defibrillators you've all heard of, what is new in that, and something called hot CRT and LOT CRT, Bluetooth synchronized home monitoring, antibacterial envelopes, which has just been introduced. We've done a few cases, and LA appendage closure. Now you're all aware of pacing system. Generally, there is a lead in the RV apex. In dual chamber system, there is a additional atrial lead, and when there is a single chamber pacemaker, you generally have a wide QRS paced regular complex. The problem here is this LBBB pattern. It's a wide QRS, superior axis, and in these patients, there is loss of AV synchrony. There is ventricular dysynchrony because you are stimulating the RV before LV, and progressively there is worsening of LV function, higher probability of atrial fibrillation. This problem is partially mitigated by doing a dual chamber pacemaker. So you have restored AV synchrony. There is PQRST here. So there is AV now synchronized, but the problem of ventricular dysynchrony still remains. LV function can worsen, especially in patients who have reverse structural heart disease, previous LV dysfunction. So then the solution for that is doing a CRT. So there is a third lead apart from the atrial and ventricular lead. There's a third lead in the LV lateral wall introduced via the coronary sinus into the lateral veins. And now you have narrow QRS here. So you resynchronize the ventricles. So AV sequential pacing is happening, AV is synchronized, RV and LV are synchronized. However, there are limitations too, because you have to put this lead in the vein in the lateral LV. There may be no veins in that specific patient, or the area may be scarred due to previous myocardial infarction, and whatever you do, you may not be able to stimulate the myocardium, or the phrenic nerve may be running just there, and if you stimulate at that point, that may be causing phrenic nerve diaphragmatic stimulation. So there are limitations. How to get around it? For the last couple of years, we are putting quadripolar LV lead. So there are, instead of 1 or 2 electrodes, now there are 4 electrodes, and I can choose whichever electrode to pace from as required. Sometimes the veins, if they are too small, I can actually put in the lead wherever I want. And now we have active fixation leads. So there is a small screw here. I can rotate the lead and fix the screw in the desired position. So it gives better stability. This would not have been possible till a couple of years ago. So with this, we are able to get around a lot of problems, but RV apical pacing issue is still there. There is an abnormal ventricular activation wavefront. It is not consonant with the natural ventricular activation, which is about onwards. And progressively, there can still be worsening of LV function. So can we do something better for this? Over the past decade or so, we moved from RV apical pacing to screwing the lead in the mid-septum. So at least partially, you are activating the ventricle in the right direction. So you are mimicking the natural activity, natural ventricular depolarization. So this is a lead in the RA. This is in a quadripolar lead. You can see 4 electrodes in the LV, and this is a defibrillator lead which has been screwed into the mid-septum of the IV, in the IV interventricular septum. Can we do something even better? So for past couple of years, now we are doing something called his bundle pacing. We are screwing in the lead into the his bundle, and we are stimulating the ventricles through the normal conduction system. And that gives rise to exactly the natural normal QRS that the patient has. And this can be done either by screwing the lead into his bundle, or in some patients, we do it by screwing the lead through the interventricular septum, and we reach the left bundle branch and we stimulate the left bundle branch. So this is schematic showing a lead in this is the atrium, ventricle, the AV node is here, and bundle of this region is here. And this is in the LAO picture. This is what it looks like. This is one of my patients, one lead in the atrium, and this is a thinner lead which is screwed into the bundle of this region. RA lead, and this is in the bundle of this region. Similarly, like I just said, for his bundle pacing, we screw it into the his bundle, but for left bundle pacing, we screw it through the septum into the left bundle, and we recruit the left bundle conduction, and that gives rise to the normal narrow looking QRS like you see here, even pace. You are used to seeing those fat QRSs, LBBB pattern. You don't see that anymore. So this is recruiting the normal conduction system, and you're getting narrow QRS. So this patient has a lead in the left bundle. We can actually utilize this very well to resynchronize better. So if a patient is getting a CRT, one lead in the atrium, one is going into the LV lateral wall, the third lead can be actually the his bundle lead. And you can then use that for CRT, and you will get what is called hot CRT, his bundle optimized CRT. And similarly, you can do it with a left bundle optimized CRT. Here, one lead is in the atrial appendage, one is in the LV, third one is in the left bundle branch. So left bundle pacing, and there's a defibrillator lead into the apex. So this is left bundle optimized CRT or LOT CRT. So this is new stuff that we are doing now. Hot CRT and LOT CRT. Now count the number of leads this patient has. 4 leads. And that can give rise to vascular problems, other issues. So leadless pacemakers are being used in elderly patients, people who have vascular issues, chronic AF with heart blocks, so who don't require atrial pacing. So in these patients, there is a special pacemaker device. It's just bigger than a capsule. We introduced it through the femoral vein into the RV, and using these prongs, it anchors onto the interventricular system and septum, and this is what it looks like. This is a leadless pacemaker. The sheath, etc., are taken out. So it's a very elegant system for certain patients. Limitation is it's a ventricular pacing only, but now this is new. We have AV synchrony even in this, so we can utilize the atrial contraction and restore AV synchrony. So this is new device, and shortly in the future we'll have leadless pacemakers, one in the ventricle, one in the atrium, and they will communicate with each other. So that will give rise to AV synchrony, dual chamber pacing. You are all aware of the conventional defibrillators. This is a lead into the ventricle, and just like you have leadless pacemakers, this is defibrillator with a lead, but it's not put through the vein into the heart, but it is put in the subcutaneous region, in the pre-sternal region. And this device, the defibrillator, is bigger than the usual defibrillator, but it's put in the infraaxillary subcutaneous region. So this is again something new. You've heard of home monitoring. The device communicates with a system at home of the patient, and that communicates with the implanter. But now again, there is new here. The device can actually communicate with an app in the patient's smartphone, and if there's any issue, arrhythmia or shock therapy, etc., given, it will immediately, I will get the message from the patient. So this is something we are implanting nowadays, and these are Bluetooth sync home monitoring. I talked a lot about devices, but there's a very real problem of infection in some patients. The risk is about less than 1% in good centers and good hands, but it can be higher in patients with comorbidities, older patients, renal failure, diabetics. And in these patients, now we've introduced using antibacterial envelopes. It elutes rifampin and tigecycline, which reduces the risk of infection by more than 50%. And I've implanted it in one of my patients, patients who get CRTDs, higher-end devices with comorbidities, or patients who had a previous infection and then need to undergo a second procedure. So this device is put into this envelope, and that is introduced into the pocket, and it gives a peace of mind to the operator. Finally, coming to advances in AF ablation, this is what we've been regularly doing over years now. Radio frequency ablation for atrial fibrillation in the left atrium. This is three-dimensional mapping. Just like the Cox-Maze procedure, this is ablation spots around the pulmonary veins. And with that, we can control or limit the symptoms of the patient. Some of these patients are still at risk of thromboembolism due to clot in the left atrial appendage. So recently, in a patient, I combined two procedures. I did atrial fibrillation ablation, and I occluded the left atrial appendage with this left atrial appendage occluder. So this is the first time actually a combined procedure has been done for a patient. AF ablation followed by this LA appendage closure with this occluder in the left atrial appendage. That is deployed and the sheath is taken out. In this X-ray, you can barely see it. It's like two spots here. LA appendage. So this is the advancements in cardiac devices over the past few years, and we are already doing it at CIMS. Thank you very much.
Thank you so much, Doctor, for the presentation. That brings us to our last presentation for the day, which is intelligent intervention through the use of biomarkers. This session will be conducted by Dr. Urmil Shah.
Basically, whenever there is a myocardial necrosis, the troponin gets elevated. And when there is a hemodynamic impact on the heart, the BNP gets elevated. And those two are the very important biomarker as far as cardiovascular outcome or cardiovascular management is concerned. Let us discuss about the troponin. We all know that troponin is a marker of myocardial injury. Myocardial injury can occur with ischemia, without ischemia. And whenever the level is more than the 99th percentile of the normal range, it is called as a myocardial injury. What we have to understand is whenever there is a troponin elevation, we have to find out whether it's a rise or fall of the elevation or a static elevation. because there are certain conditions like chronic myocardial injury where patient had a static troponin elevation. Whereas in acute myocardial infarction or the ischemia, there will be rise and fall in the troponin levels. This is the definition of myocardial infarction, which tells that there has to be at least one value, 99 percentile above the normal range. At the same time, there is a fall or a rise of the biomarker with the evidence of myocardial ischemia. So what we have to understand is whether there is a stable troponin level elevation. It can be a chronic myocardial injury. It may be because of structural heart disease or kidney disease. If there is a rising or fall in the troponin level, if it is associated with acute ischemia, then it is probably a myocardial infarction, and it may be two types of myocardial infarction because of the atherosclerosis or the thrombosis, which commonly see type 1 MI, or with the oxygen demand imbalance that we normally see in severe hypertension or sustained tachycardia. And if there is no acute ischemia, then it is probably acute heart failure or a myocarditis. These are the other causes of myocardial troponin elevation. We have to understand it may be post-PCI, post-CABG. Infection in the heart itself can cause malignancy, cancer, chemotherapy, infiltrate disease, or certain non-cardiac disease like pulmonary embolism, sepsis, renal failure also can cause elevation of troponin. We also have to understand that it's in COVID era, troponin elevation can be because of the COVID itself, and we know that whenever it is elevated, it has a high prognosis. Compared to the contemporary troponin, HS troponin is found to be more precise and more accurate. At the same time, we can identify the rise much early. That means within 1 or 2 hours of the onset of chest pain. So that is the advantage of using HS troponin. As you can see here, because there's reduced time for getting it repeated, and that is the reason we can have early discharge of the patient, and cost also reduced. At the same time, we can identify those patients who are having elevation of troponin and myocardial infarction, and we can treat the patient and we can reduce the mortality in this patient. These are the different approaches we can keep in mind, as you can see here. And this is the 1 hour baseline or 2 hour or 3 hour protocol which can be used. What we have to understand is if the ECG is showing ST elevation, it straight away goes for the intervention or a STEMI guideline. If there is an elevation which is 5 times more than the normal range, definitely it's a high risk for MI and patient should undergo a cardiac workup. If it is not so high, then we might have to repeat it at 2 hours. And what we have to keep in mind is baseline level, and at the end of 2 hours, if there is a significant change, then it is suggestive of acute myocardial injury, and according to we have to manage. Suppose this is a patient who is a 46-year-old guy who is having elevated lipid borderline. A patient had a chest pain which just started several hours before. Otherwise, all the findings were normal. Troponin, creatinine also was normal. And if you look at the HS troponin, initially it was 0.36, and at the end of 3 hours, when we repeated, it gone down. So basically, there is a fall in the troponin level, and this basically is suggestive of acute ischemia. Patient underwent angiography. There was a tight block in the LED, and angioplasty was done. This is another patient who is having chest pain, shortness of breath, pedal edema. Is a known case of CRF. Creatinine level was very high. His baseline admission time at chest troponin was 0.32, and at the end of 2 hours when we repeated, it was same. So it is a chronic persistent elevation. A patient did not require any intervention. It was because of the chronic renal failure. This is another patient who has come with a chest pain, 55-year female patient. Initial troponin level was normal. We repeated it after 2 hours, and what we could find was there was no significant change in the level. So practically, we can discharge the patient safely. I'm ruling out myocardial infarction. Coming to the BNP, we all know that BNP because of the intracellular, because of the voltage. And it has 2 components. One is anti-pro-BNP, which is an inactive molecule, and a BNP, which is an active molecule. And we know that BNP is a useful marker for benefit as far as heart failure is concerned, and it is inhibited by neprilysin. So this is the recommendation, which clearly tells that if you want to support, this is biomarker, it should be used for support as well as the exclusion of heart failure. This is what is important. So suppose the patient has a clinical issue of heart failure, physical examination, ECGs are suggestive, and you are to first and foremost get an anti-pro-BNP. If anti-pro-BNP is high, that means we are dealing with a cardiac problem and we have to manage accordingly. And echocardiography is primarily done, whether patient is having reduced ejection fraction or a normal ejection fraction, that we have to find out from echocardiography. So this is the cut point, as you can see here, BNP level less than 100 or anti-pro-BNP level less than 300 in acute onset practically can rule out the heart failure. As you can see here, if you use this marker in the emergency room, practically it can save the time, and we can start the treatment very fast, because if the BNP level is high, it's a heart failure and we can start the treatment very early. What about the chronic heart failure? If you look at it, persistent elevation basically is we have poor prognosis, or sometimes at baseline it is low and follow-up it goes high. That means treatment does not work. At the same time, if it falls down, then definitely it's a significant improvement as far as outcome is concerned. And this is a recommendation, as you can see here, for the diagnosis. If the patient is having stable heart failure and the patient comes with a new onset breathlessness, or in the BNB can be used as to rule out or rule in of heart failure patients. At the same time, for prognosis, the patient who is NYHA class 2, at the same time, those who are hospitalized, we can prognosticate this group of patients. At the same time, pre-discharge BMP also is very helpful to know that whether the patient can be discharged or whatever is going to be the long-term outcome. At the same time, we have to know so many conditions which can cause elevated NT-proBNP. It is non-cardiac conditions, also like pulmonary embolism, myocarditis, renal dysfunction, subarachnoid hemorrhage, liver dysfunction. So that also we have to keep in mind. In the present time, COVID also we have to keep in mind. So there are vulnerability of natriuretic peptide, preserved ejection fraction also can have NT-proBNP high. Age also can have some variation. Renal function and atrial fibrillation, obesity also affect the BNP level. Sacubitril valsartan, whenever it is used, you have to be very careful. Suppose the patient is on sacubitril valsartan, BNP level is going to go high, and that we have to keep in mind. And if it is high, then it is not that patient has not improved. It is because the mechanism of the molecule is such that BNP is going to be high in this patient. This the patient is the 56-year-old guy. He is having COPD. Injection fraction is 65%. Patient is worsening of breathlessness last 2 or 3 days, and we don't know whether it's a cardiac or because of lung problem. Other findings are by and large okay, except blind basic cracks were there, and we don't know the reasons of breathlessness. And what we did the NT-proBNP, it was found to be very high. So definitely this is the patient who is having some cardiac reason because of his symptoms at present. Suppose this patient's NT-proBNP comes as 70. So definitely we can rule out that it is because of heart failure and it is primarily because of the lung problem. So this is the advantage of ruling in or ruling out of heart failure patient. Another patient is 67-year-old guy, 7 years back had MI. Angioplasty was done, ejection fraction of 32%. Patient was relatively stable on the routine medicine. Patient had a breathlessness on exertion. Otherwise, on routine work, no breathlessness. And his NT-proBNP level was found to be high. So basically, though the patient is clinically stable on the medicine, we can say that this is not a otherwise stable patient. We really need to modify treatment in this patient. So many times, NT-proBNP can find out whether the patient is having unstable patient or a very stable patient, and definitely we can switch over from ACE inhibitor to ARNI or immunocorticoids can be added as for the treatment. At the same time, this is the meta-analysis which can tell that hospital mortality also can be seen. Pre-discharge also is very important. At the same time, we can motivate the patient. It's something like a HbA1c which we are using. Suppose HbA1c high, patient also understands that my diabetes is not controlled. Similarly, NT-proBNP is high. We can tell the patient it is not very nicely controlled. Another risk stratification, also BNP can be used for pulmonary embolism. If it is high, then it is a bad prognostic marker. And the acute coronary syndrome also, if you look at it, any group of patients, if NT-proBNP is high, it basically carries a bad prognosis. Pre-operative for non-cardiac non-cardiac surgery also, if NT-proBNP is high, it carries a high risk. Pulmonary hypertension also, it can risk stratify into mild, moderate, and high risk for a pulmonary hypertension patient. And for all the research is for research purpose or newer trials which are going on, NT-proBNP is basically the inclusion criteria which is used in most of our patients. Last 1 or 2 patient, which is a biologically active substance which is inhibited by neprilysin, BNP or NT-proBNP. So active substance is BNP, that is one. And suppose the patient is on ARNI, the patient is tolerating this, what do you expect? Sacubitril valsartan combination will increase BNP, it will increase NT-proBNP, or it will increase the both. Here also it is first, it will increase the BNP level. Thank you very much.
From the entire team of Docplexus, I would like to express gratitude to all our speakers for today. Thank you for taking such insightful sessions on such pressing topic. We hope to hear from you again. And to all our viewers out there, thank you for coming back to the platform and attending these lectures. I hope you took some insights away. We will be back another Thursday with a new interesting topic. Till then, stay safe, stay connected. Happy Docplexing.